Pause. He was a 53-year-old man with long-standing heavy kratom use, reportedly taking about 15 grams 3 times a day. After taking one of his usual 15-gram doses, he became regretful and decided to take 50 milligrams of naltrexone in an attempt to stop. Given his chronic high-dose daily kratom use, the naltrexone can likely precipitate a sudden and severe withdrawal syndrome. That detail is the hinge of the case. His family became worried and called for help. When he first arrived, he was awake, alert, and oriented to person, place, time, and situation. At first glance, he did not look critically ill. Then the picture changed fast. After arrival, he developed a presentation very consistent with precipitated withdrawal, meaning withdrawal that begins suddenly and forcefully after a blocking medication, displaces opioid-like activity from the receptors. In plain language, his body had adapted to regular kratom exposure, and then naltrexone abruptly shut that door. Hard. He became altered, severely agitated, hallucinating, diaphoretic, and physically combative, to the point that restraints were required. He was described as thrashing back and forth despite treatment. On examination, he was also noted to have slightly unequal pupil size. This was not a small reaction. Initial evaluations showed hemodynamic stability without shock, but the electrocardiogram revealed a prolonged corrected QT interval, raising concern for electrical instability, especially in the setting of agitation and electrolyte disturbance. Toxicology screening was otherwise unrevealing. Blood gas analysis showed alkalemia with a low carbon dioxide level, consistent with respiratory alkalosis. Laboratory studies were notable for mild hypokalemia, mild hypomagnesemia, and leukocytosis. Renal function, muscle injury markers, and liver tests were otherwise reassuring. All of that fits. For healthcare readers, the mechanism is familiar. For kratom readers, the key point is simpler. In someone using kratom heavily every day, a medication like naltrexone can trigger a sudden and severe withdrawal syndrome. Even if kratom is discussed differently from traditional opioids, the receptor story can still hit with real force. No, not just stress. No. In the emergency setting, he received lorazepam, olanzapine, and ketamine. Ketamine helped somewhat, but not enough. He remained severely agitated and continued thrashing. During discussion with the toxicologist, high-dose buprenorphine was recommended as the preferred escalation strategy, with additional doses considered if there was clear benefit. Another option discussed was a high-dose fentanyl infusion, although buprenorphine was considered the safer path. Dexmedetomidine was also discussed as a reasonable bridge if his blood pressure and heart rate could tolerate it. But there was a practical problem. Buprenorphine under the tongue only works if it stays there long enough to absorb. In a patient who is hallucinating, thrashing, and unsafe, that becomes difficult in a hurry. Bedside reality has a vote. Because of persistent, severe agitation and the inability to safely control symptoms otherwise, he was ultimately intubated. He was then managed with dexmedetomidine, ketamine, and later propofol, along with intravenous fluids, magnesium replacement, potassium replacement, and thiamine. Management then shifted into supportive intensive care, while the team rode out the withdrawal storm and corrected the electrolyte abnormalities, contributing to corrected QT interval prolongation. That was the pivot. On later follow-up, he remained intubated and sedated on a propofol infusion. He was hemodynamically stable while mechanically ventilated. He also received as-needed midazolam, continued intravenous fluids, and ongoing supportive care. Electrolyte replacement had been given, and the plan was to keep him sedated through the night and reassess after additional stabilization. Reasonable, controlled, necessary.
On subsequent follow-up, the case had clearly cooled off. He had been extubated, was receiving supplemental oxygen by nasal cannula, and was described as cooperative in following commands, while maintained only on dexmedetomidine. Repeat vital signs were reassuring.
And the laboratory picture had improved as well. Repeat studies showed correction of the potassium and magnesium abnormalities, stable renal function, and improvement in the leukocytosis. A repeat electrocardiogram had not yet been performed at the time of follow-up. Recommendations were to continue supportive care and watch for any ongoing or recurrent withdrawal symptoms.
So what is the takeaway here?
This was an older adult man with chronic heavy kratom dependence who took naltrexone after kratom and developed severe precipitated withdrawal, marked by agitation, hallucinations, diaphoresis, violent thrashing, and altered mental status, along with corrected QT interval prolongation, electrolyte abnormalities, respiratory alkalosis, and leukocytosis. He required escalating sedation and ultimately intubation, but improved significantly with supportive intensive care, sedation, intravenous fluids, and correction of electrolyte abnormalities. For clinicians, this case is a reminder that kratom dependence can behave in very opioid-like ways when receptor blockade is introduced abruptly. For kratom users, the message is not panic, it is caution. If someone is using kratom heavily every day, then medications like naltrexone can trigger sudden and severe withdrawal. That interaction is real, and sometimes it gets dramatic fast. Mechanism matters. Timing matters. Thanks for watching Medical Toxicology channel.